Good morning. Good morning. On behalf of the MBA Healthcare Club, we wanted to thank you guys for coming today. Thank you for spending your day with us. We're very excited about this. We wanted to just quickly thank our sponsors who helped put this on. Thank you to our speakers who are taking the time out of their day to educate us on all of this great stuff. And of course, thank you to CBOH for all your guys' work and help putting this on. Aaron, Suzanne, thank you, thank you. We're very excited. If you guys need anything throughout the day, please find the people with the green on their name tag. We are the volunteers, and we can help you out with whatever you need. So with that, I'll pass it to Professor Staats, and we'll get it kicked off.
Great, thanks y'all. Welcome everybody on behalf of Dean Mary Margaret Frank and Kenan-Flagler Business School. Thrilled to have y'all here today. And as we really gather across UNC, and this panel is a perfect representation of that as we dig into kind of this topic of strategic workforce. So I'm Brad Staats. I am our Senior Associate Dean here for Academics and also Faculty Director for the Center for the Business of Health. And we'll be moderating this first panel, really a dream team across our UNC health services schools, thinking about kind of the maldistribution of the clinical workforce. So working across the panel here, have Dr. Samantha Meltzer-Brody next to me. She is the Asad Memandi Distinguished Professor, as well as the Chair of the Psychiatry Department at the UNC School of Medicine, also the Director of the UNC Center for Women's Mood Disorders. Next to her, we have Dr. Cheryl Jones. She is the Sarah Frances Russell Distinguished Professor at the School of Nursing, as well as Associate Dean of the School of Nursing Transformation, and the Director of the Hillman Scholars Program. And then next to her, we have our Dean, Angela Kashuba. She's the John A. and Margaret P. McNeill Senior Distinguished Professor, as well as the Dean of the UNC Eshelman School of Pharmacy. So represented, we can think about medicine, we can think about nursing, we can think about pharmacy, and obviously a lot more than that as we work our way across this kind of topic of the maldistribution. And what we want to do is spend some time up here kind of learning and kind of conversing across our panelists about the challenges, and then importantly about how do we kind of move forward, right? What are the steps as we integrate, as we think about kind of the public policy aspects, as we think about the business aspects of all of this. And so let's start with the challenges. And so, we'll start with Dean Kashuba, that as we think about pharmacies, rural pharmacies are closing across North Carolina. This is creating a number of gaps, especially in places where, pharmacists might be the only healthcare provider. And so could you share a little bit about why you see this happening?
Sure. Well, I appreciate the opportunity to be here and to speak about this topic and to be here with such distinguished colleagues. So the pharmacy business model is truly broken. And I think that's the biggest issue. So the community pharmacies, whether you're an independent community pharmacy or whether you're a chain pharmacy like Walgreens, they are operating now on very thin margins, and often they are getting reimbursed for a medication from an insurance company or from a PBM that is less than the cost of acquisition of the drug. So you're getting reimbursed at a deficit. It's hard to maintain a business in that way. And so there are stores that are closing that they just can't see a way forward. And even with clinical services, patient interactions, things that they used to do when they had a margin and were able to operate in that space and work with patients more closely, even reimbursement for those types of services is fractured, and so it's difficult to create a sustainable business with just those low margins, that inability to get reimbursed for cognitive services.
Sorry. Thanks for the start. And let's talk kind of nursing next. Cheryl, we know that we face a large nursing shortage in North Carolina, estimated around 12,000. Hospitals in particular facing challenges there. Can you kind of paint the picture a little bit for us of what's going on and what's driving that?
I think it's on now. Thank you so much for having us here today and convening us to talk about this really important topic that does span across different areas and disciplines of the health workforce. I would just say that there are several reasons for the challenges we're facing. I mean, I think we're all familiar with sort of the hangover of the pandemic effect. We still have that for sure. But it depends on who you ask about the reasons for the shortage. If the American Association of Colleges of Nursing lists the underperforming enrollment, so there's a lower enrollment of students, but there's also a shortage of faculty such that we can't admit the number of qualified applicants that apply to schools of nursing. I've seen the number between 65 and 70,000 nurses or applicants are denied admission because of the faculty shortage. Those of us on the faculty side have been aware of that shortage for some time, but I just saw a recent article that said it's the hidden cause of the nursing shortage. Don't know that I'd go that far, but it is a problem. We also know that we have, like the larger labor workforce, we know that retirements are looming. I've heard 2/3 to 75% of the workforce 2/3 of those over 65 will be retiring in the next few years. And nurses, we really do have a problem with retirements and the replacement of people who leave the workforce, because the ones, as I mentioned, coming in are not sufficient to replace those who are leaving. We also there's an aging population, so just as nursing is aging out, our population is aging and needing more care. And then finally, the American Association of Colleges of Nursing also acknowledges the staffing concerns and considerations. If you talk to nurses, so that's on the bigger side of things, the system side of things. But if you talk to nurses are concerned about staffing and the workload. They're concerned about the feeling undervalued. They're concerned about pay. And they're concerned with about the working conditions. The working conditions in nursing are often described as poor, and they fluctuate between whether or not the industry is focused on costs or quality. And right now we're somewhere in between that, I think. But nurses tell quite a different story. And then we also know that during the pandemic, we saw a rise in things like workplace violence, which has always been there, but it just really came to the surface during the pandemic. And since the pandemic, it's been prevalent.
So a daunting list for us to try to unpack. So far, let's add one more. Samantha, you could talk a little bit about behavioral health, and we know there's kind of a maldistribution, particularly in disadvantaged areas, but kind of how do you think about that, and how have you seen that evolve?
So one of the most interesting things over the past almost 5 years, since March of 2020, is that mental and behavioral health, which has been underfunded and neglected for decades in this country, suddenly it became very important to everyone. And with the ability to deliver virtual care, which happened in March of 2020, it wasn't like the technology wasn't there the week before, and the payers decided to start paying for it, and that has continued. There is an amazing opportunity for us to have a transformative period. So I think that the shift from mental and behavioral health is something that happens to other people, not me, and for the decades and decades of poor reimbursement, which means healthcare systems did not scale up because it was a losing proposition. This is the business school, so getting the healthcare systems to scale up in something that loses money, particularly for those who are publicly insured, led to where we are now with private practice, fee-for-service, and then everyone else has to find the public sector or an inadequate number of clinicians that take private insurance because the reimbursement has been so poor. Now that mental health concerns impact everyone, I would ask anyone in this room, has anyone not been impacted in some way? A family member, a neighbor, a friend? There's no way that people would say no to that. And suddenly everyone has decided, well, this is a crisis that needs to be addressed. And that, I think, is an incredible opportunity. So leveraging virtual care what we have seen here, we've doubled the size of our clinical footprint because of the support of UNC Health, and that's largely because of using virtual health to reach rural communities. Because historically, mental health professionals do not live in rural communities. Now, I can't tell you exactly why that is, except it seems to be a group that likes a diverse, restaurant scene, and congregates in sort of this more, if you will, I don't know, they want a more sort of more bells and whistles of what's available. And that has been horrible. So half the counties in North Carolina don't have psychiatrists. Everyone is congregated in the big cities. But with virtual care delivery, we now have delivered, and this is all brand new, UNC Health started virtual care. We've been able to hire folks that live in the Triangle, and now are delivering care. We've done 6,000 emergency room consultations. We're running virtual inpatient units at UNC Health entities in rural areas. And then 62% of our routine outpatient visits are now virtual care, which is why there's been this explosion in telepsych virtual platforms. And I think we're just at the beginning of that. So there's huge issues, but there's also, I think, amazing opportunities now. And I think all of us working together, we can really move the bar in a powerful way.
I appreciate the optimism as we work our way across. We have kind of supply concerns, we have kind of operational concerns, we have payment concerns as we think about all the different aspects here. I want to talk a little bit about kind of the policy and the business environment. That if we think about healthcare, one of our key challenges is that the two are kind of inextricably intertwined, that you can't just look at one or the other as you're highlighting kind of the macro policy environment kind of sets things up, but we have to figure out the business models that function within, and then back and forth as we evolve and innovate. But kind of let's start on the policy side and think about kind of what would you highlight there as you look to change, as you think about you mentioned kind of COVID came along and suddenly now we can do telehealth. We could do it before, we just couldn't get reimbursed for it before. It's a pretty fundamental change. As we think, and maybe we'll kind of go the opposite direction, as you think about the environment and policy and certainly, figuring out what policy is going to look like going forward is an open question. So you can incorporate that or not as you want to think about. But what role might policy changes play in kind of addressing these challenges you've highlighted?
Well, I think policy is critical. So there's been the battle for parity legislation so that insurance companies could not have behavioral health carve-outs, which essentially meant if you had a behavioral or substance use concern, it went to a different types of policy, which generally were poor. The reimbursement poor, the number of visits poor. And in particular, like you can only have X number of visits for this condition, which we don't say to anyone that has hypertension or cancer or diabetes. So just frank disparities that led to the place we are now. So with the parity legislation that's occurred over sort of the past decade plus, there's much more coverage. And I really think that we have got to see mental health, behavioral health, the same as we see any other medical condition. And we need to just have reimbursement be the same as it is for anything else. That would be a game changer. If the reimbursement matched other things, then healthcare systems will be very happy to scale up because it will not be a money-losing proposition. So I really think the answer is in how we work with payers and coverage to develop metrics and quality and return on investment, but that we see it no different than any other health concern. I think the number of people needing help, I think you'd see a complete change. The business model would completely change. And with the ability to use virtual care and all the digital platforms, I think we can transform what we do in ways that we haven't. But I'm always humbled by, if you have a ridiculous business model, you can't get anywhere. If the business model is we're going to reimburse you some tiny percentage and it's going to lose money, that is not a sustainable business model. So until we get that fixed, I think policy can really focus on that. Now there's signs things are moving in the right direction. CMS has been increasing reimbursement rates for mental health. That's a positive sign. It needs to keep going in that direction. And I will tell you that the world now is filled with young people that want to be mental health professionals. Psychiatry residency applications have never been higher. In fact, all of us who are old, we look at the applications and we're like, who knew the board scores went that high? You know, I mean, as they're applying, and they're just remarkable young people interested in psychiatry, which previously had been as like the third-class stepchild of the medical profession. But you see this in all areas of people wanting to enter mental health in a variety of ways, whether, you know, it's in nursing, psychiatric nurse practitioners, whether it's in social work, whether it's in master's level, PhD, pharmacists that collaborate. I mean, there's huge opportunities for us to look at the workforce broadly in this area.
Awesome, sure.
Thank you. I agree. You know, we've seen a lot of nurses very interested in psych NP, becoming a psych NP. On the entry-level side, I don't know that there's been an overabundance yet of nurses interested in going into behavioral health, but it may soon follow. If the money, as the money flows, so does the workforce. But I will also say that I look at policy sort of at the big P level, public policy, the system level, and then clinical practice policy. But at the big P level, I think certainly through the Health Services Resources Administration, funding, investments in nursing education really is needed. As Dr. Meltzer-Brody mentioned, we didn't do virtual care before March of 2020, and so hospitals and nursing in the discipline had to quickly shift to take on this virtual nursing care. And what we see now is very experienced nurses guiding and providing advice to nurses on units delivering care to patients or delivering care through emergency rooms through virtual services. So I think part of the issue is training the workforce to go in and walk into a virtual space. On the education side, we also need to train using things like simulation. In nursing, we up to 50% of the education can be provided through simulation. So our regulatory bodies allow that. So we're on the education side trying to scale up. How can we get the technology, the equipment, the space, the physical space to actually deliver simulation? And we're getting better at it, but we still have a ways to go. And then there's virtual reality, which we are using in nursing education quite a bit. So I think the policy side can certainly support those investments on to educate the future workforce. On the system side, I think there's some issues that probably need to be addressed, or not probably, that need to be addressed around changing the work environment, truly changing the work environment to make it a more, a place where nurses feel valued and where nurses want to work. I mean, we saw so many nurses leaving during the pandemic. I mean, at first, nurses were the heroes, right? They were hailed as heroes. It didn't take long before that shifted. And so then nurses started to leave because they needed to care for themselves and their families and their loved ones. So we really saw a turn where nurses went from feeling valued to feeling very undervalued. And that hangover effect is still there. So I think on some level, changing the work environment, really improving the care. We know nurses, physicians, pharmacists are burned out. I mean, the workforce is burned out. So I think some attention to that on the system level. And then in clinical practice, we do things like make decisions about staffing. We float nurses. We, use a lot of travelers. I'm sure many of you have heard about that traveler workforce that we've had to hire during the pandemic, and they're still there. Although some of the workforce is coming back, it's not fully back. So I think organizations and units are trying to bring on permanent staff, but they're not always easy to get. So I think there's some practice level improvements that can be made in terms of the help that nurses need at the front line. Nurses are on the front line, right? Especially in hospitals. They're there 24/7. They're the closest, probably the closest person to the, or a provider, clinician to the patient on a day-to-day basis. So I think some way that we can improve that environment, work environment, and the staffing levels would go a great distance in terms of improving the workforce.
I love that you talk about frontline because we see the same thing with pharmacists, particularly in rural communities. Oftentimes, that brick and mortar pharmacy is the front door to health for most patients. They may see their provider, once a year. They are seeing their pharmacist 10 times that, or they're in their pharmacy 10 times that. So we really have an opportunity as the front door to health in these communities to bolster the ability for pharmacists to take care of patients. So I think there's two things. One is for pharmacy, pharmacists are not considered providers. There's no provider status for pharmacists. So that creates a challenge in terms of getting incentives for tuition reimbursement, loan repayment, those sorts of things. So that is a significant barrier, particularly in rural communities. And so to be able to have some policy changes around that, I think would help tremendously to keep pharmacists in rural communities. The second thing is that pharmacists really want to be part of team-based care. We have got so many examples, even within North Carolina, that we can talk about a little bit later, around where pharmacists working in collaboration with physicians, with nurse practitioners, with others, on medication therapy management, medication optimization, medication adherence, improve health outcomes, reduce costs, reduce ER visits, improve clinician well-being as well. There's a lot of opportunities for us to fill gaps together, but there's no good incentives around team-based care. And we have opportunities here, I think, in North Carolina to start changing the model and demonstrating real benefit in health outcomes for our North Carolinians. So there's some policy changes that could occur around this team-based reimbursement, and payment parity, critically important, I think.
Great, thank you all. And I think as we think about the macro environment, I love kind of the number of different examples. You can think about how we might change it to increase the likelihood of success. I want to zoom in kind of on more the business model side, the business innovation side, as we think about living where we are now, right? And so kind of how do we take a lift where we stand approach and think about the role of business defined kind of very broadly. To help kind of innovate, to help address some of these infrastructural issues. Where do you see either actions already taking place, perhaps, or the opportunity for us to do it? And I mean, maybe we'll keep working our way back and forth. So we'll start at the end again.
Yeah. So a healthy workforce is a productive workforce, right? So I mentioned. Pharmacists working in collaborations with other clinicians. So back in the 1990s, 2000s, we had the Asheville Project. So the city of Asheville paid pharmacists to work closely with their employees around chronic medical conditions. They wanted to improve diabetes management. They wanted to improve hypertension management. And when they did that, they found that more patients got to goal for hemoglobin A1C, more patients had normalized blood pressures, less ER visits, less hospitalizations, less sick days. So if you can create an ecosystem around utilizing all of the health professionals that are available to fill gaps and not just rely on one particular health professional to solve all problems, I think that goes a long way. So when businesses are looking at health plans, for example, most of the time it's an HR department that's evaluating a health plan and making some decisions on that. But what I don't think the HR departments necessarily understand is what are all the activities that are going to lead to a healthy employee. And so I think we might need to do a better job even on education around health plans and what really produces good outcomes and cost savings in the end. You may be paying upfront more to try and fill some of these healthcare gaps, but in the end, you actually save more on the back end, both in terms of healthcare costs and in terms of employee productivity.
I think there are opportunities for certainly business service collaborations. In nursing and in the healthcare arena, we're trying to build academic service partnerships, and those could be partnerships between academia and the healthcare providers, hospitals, other groups, but also with the business sector. Nursing hasn't always, developed those close ties to the business sector, and I think that would really be a great opportunity for the discipline to engage in more of those collaborations to address things like the technological issues that we face. And as also, speaking of this going into this virtual space, I think that's something that would be a terrific partnership between the clinicians and the business sector to address things like the virtual care.
I think that there's huge opportunities for public-private partnerships. And one of the examples that comes to mind is the electronic health records, Epic, still owned by a single person, which has taken over medicine. I mean, Epic really designed as a billing system. And what it has done, there's things that are good, but now clinicians spend most of their time charting. And having to be basically a slave to the electronic medical health record and all the bells and whistles of it is burning people out. And the workplace violence issue is completely unacceptable, and we need to address that. I could not agree more. So I think that how we figure out to partner together on different ways to interface with Epic, because Epic's not going away, or Epic's cousins, to make life better for the patient and the clinicians. And we haven't done that yet. I think that there's huge opportunities to think, what's the initial access? How do you access care? What does that look like? How can we use digital platforms as the front door? How do we think about continuum of care from I have a little bit of this to I need to be in an emergency room? And how do we develop responses? Again, with, I think, public-private partnerships where business can play a huge role on that continuum of care. And we have to utilize team-based care. I couldn't agree more. And I think there's some great pilots where this works really well. But the stepped care model, for which there's great evidence, collaborative care models, integrated care models, there's huge evidence for all of this. It's just that there's been a lag in reimbursement. And I know I've said this multiple times this morning, but certainly from a business perspective, if you don't have adequate reimbursement for services, then you don't have a conversation. So how can we work together to do that so that we create something that meets the needs of the patients we serve and enables the workforce to be engaged and well? And I think people really are excited for this, and I just think it's a very sort of different way of viewing where we've been and where we need to go next. One example that I think would be ripe for investment is, in terms of the youth mental health crisis, is school-based care. Where are the kids? They're in school. We should be using virtual platforms. We're doing that. We have multiple different school-based things. We should be investing in that in a public-private partnership to say, how are we going to change the way our kids have, mental health literacy, education? I think every kid should be receiving CBT training, in middle school or earlier. How do we then have a range of services that are accessed by the school? How do we do that so it's a statewide solution or a national solution, which very much should involve business and helping to develop that, just as an example. So I think that we have to think differently and think collaboratively.
Yeah, I love the examples as we think about that cross-sector collaboration, and we think about, as you're highlighting, some of those cross everywhere, some of it are particularly important in our underserved areas, and recognizing often, business in certain communities may be the driver, right, as they think about how do they get their workforce, how do they make sure they understand what well-being of that workforce looks like, but also creating the investment around them so that folks want to stay in that community and they can make sure they're sustainable as we go on. One business trend I'm curious, and I'll open it to all three of you because I don't know who might want to reflect on this, is the corporatization of medicine. And so we certainly can think about I mean, really across all these elements that we see the rise. And like anything, there's promises and perils to that. And so, how do you think about that? And maybe actually, I can start with whomever. How do you think about how that might either help or get in the way of some of these challenges of underserved areas?
I don't know. I'm going to pass that over to somebody else.
Fair.
We talked a little bit earlier about profits versus outcomes, right? And so I'm a Canadian and come from a very different healthcare system, which has its own set of problems. But this issue of health for all versus only health for some is a challenge for me, even after spending more of my life in the U.S. than in Canada. But I do, I see, even if we just look at medications, right? So we have $800 billion spent on medications in the U.S. 400 billion, half of that is actually on medications. The rest is going into a profit structure that, when you think of that amount of money and the good that it could do for populations, for rural populations in particular, populations at risk in particular, it's a real struggle. I think the struggle is real, right? And trying to, as I've talked to some of our legislative colleagues around investment in services, the model of how you invest in services is, well, how much is it going to save me this year, not how much is it going to save 5 years from now. So even those types of models around only thinking about short-term savings versus long-term, you can't do prevention strategies short-term. Those are long-term. So I think we have a system that is very challenging to work in. When you're trying to provide the best care possible, you're playing a long game in healthcare around healthy populations. And I don't know what the resolution to that is, but I think it is extremely challenging to be able to provide healthcare to all in this kind of environment.
I couldn't agree more. I think medicine has become corporatized. I don't see that changing. I mean, the reality is we can't really afford the current healthcare system we have, where everyone wants all the bells and whistles of everything all the time. So how do we work within that? And it remains a major challenge because we do not have a long-term plan. I think we're moving from crisis to crisis. And since the pandemic completely upended healthcare, so the cost of doing business is now much higher than it was before on everything. Except the reimbursement is no greater for what's coming in. So margins are smaller broadly. How do you innovate in that space? And I think that we have to get alignment on what do we want the outcomes to be, and then start working towards that. And as you said, it's a long-term solution. But if we had alignment on what that could look like, I think we could do great things. It's really like everyone's just like trying to, stay above, the water right now. There's a lot of just keeping your head above the water, which doesn't lead to long-term strategic planning or getting alignment of the private-public, partnerships to do good. And the people that lose are the patients. And so ultimately, I think that the patients are losing. If you look at what's happening in rural America, which is, and you see this also in other settings, you have deserts of pediatric care. You have deserts of obstetrical care. You have deserts of mental health care. You have deserts of primary care. And then that leads to all kinds of terrible things. So I do think that if we started aligning on what are long-term outcomes and how can we work together, we would be much better off.
So, sure. Yeah, I want to jump in now. We had a big event happen this week, right? And so the healthcare system is likely to become even more corporatized than it is right now. So I think we may need to be prepared for that. For example, CMS is likely to be pushing more Medicare Advantage than its current traditional plan that people can go into. So there are going to be many changes likely with the new administration at the helm of the U.S. But the question is, I mean, we always go back to what outcomes do we want? Both of my colleagues have mentioned that. But I think the bigger question is around access to care, which you mentioned is around quality of care. What level of quality do we want? And what do we need to invest in our system to then get that level of quality? And I think innovation, you mentioned innovation, Samantha. I think innovation right now, we don't have the resources to do that innovation. So that's certainly where, if we had greater investment from the business side on the innovation around healthcare, you mentioned electronic health record, and you also mentioned the clinicians' dislike of up and down the scale, essentially, with the electronic health record, because they spend all their time documenting. So if there are ways to gain efficiencies and invest in efficiencies in the system, I think that would ease everyone's minds. Patients are waiting now, since the pandemic, months still to get appointments. I talked to my cardiologist colleagues. Patients can't get into cardiac rehab after they have an MI for months. The guideline says 6 weeks. They don't get in 6 weeks. So investments in other strategies to help patients get the services they need. For example, cardiac health promotion after a cardiac event would be an area of investment that could go a long way to help patients that are experiencing our number one disease in the country.
So this is, I want to ask one question, well, same question to two and then a different question. But one more question down the panel row and then want to open it up to the audience. So be thinking about kind of most impactful questions. Both Samantha and Cheryl, to you, want to hear about kind of how telehealth virtual services might help us do a better job of impacting care in these underserved areas. And then Angela, ask you about the team-based care point that you'd raised earlier and how we think about in the same way we might approach things kind of more innovatively. So let's start, with you.
So I believe strongly that telehealth virtual care platforms are transformative, here to stay, increase access. And I was telling Angela earlier, I've been working on this PCORI mental behavioral health report that's due in a week or two and will be publicly available. And so I've now reviewed all the literature on all these things, very late at night for many months. So there is lots of innovation and just explosion of digital platforms. And if we talk about behavioral health, for which it's very readily accessible. It's hard to do virtual surgery, but it's very readily available, and there's been this explosion in telehealth and behavioral health. The quality of what we're offering is very disparate. And so I think someone can come up with what they think is a jazzy new thing, but does it have the quality? Has it been tested? Does it show outcomes that really work for patients? How do people access it? Is it really expensive and you're only delivering fancy care to fancy people? Is it a population-based health model? So I think there's huge opportunities in that space. I'm excited to see where this goes next. And this is where I think the partnership with, again, private, public, working together, using AI, thinking about, again, what is the point of entry for access? How do you then scale things up appropriately? How do you integrate technology? I know UNC Health is going to be bringing AI in to try and unload many of the tasks that just, burn out clinicians. So it's an exciting time. But telehealth is here to stay. I really wish the payers would stop, sort of saying, well, we're going to reevaluate whether we're going to continue to cover. I'm like, really? We're like 5 years out, and 62% of all mental health care is delivered virtually, and it, decreases barriers, decreases stigma. The evidence shows it's as effective. So can we stop talking about, whether or not you're going to stop paying for it? Because that's really not helpful.
Yes. telehealth is here to stay. And so the question is, how do we train? How do we ensure that telehealth is delivered in a way that promotes well-being and decreases burnout among the workforce? And how do we ensure that the quality of telehealth services we provide is equal to or better than, continue to support the high level of quality? Hopefully it will improve the quality. I anticipate that it will, and it does, improve the quality of care that patients receive.
Could you say a little bit, Cheryl, on, you'd mentioned before kind of virtual services and what that unlocks for nursing, and how that's kind of, innovating within the model?
Yeah, it unlocks great opportunity for nurses. We are learning how to practice in that model. I think the issue around virtual nursing is the state of the nursing workforce. Do we have the experienced nurses? Because you can't put somebody right out of school into a role that requires experience, critical knowledge, and an advanced level of care that you are, wisdom, if you will, that might come from experience. So I think we have to get both the nurses in the workforce who do have experience ready to move into those roles, and I think we need to train nurses entering the profession to go into their roles expecting that they're going to be guided by an expert nurse, if you will, and expert clinicians, and then see themselves moving into that role into the future. I think it's a way to actually reduce some of the workload burden in nursing greatly if we do some additional work to get it to smooth the transition to telehealth, the continued transition. I think also the team-based care, which I know Angela's going to talk about. Team-based care is essential. And how do we do team-based care well in that telehealth model? We're doing it, and I think there are opportunities for growth there.
That's great. Angela.
So first, I do want to address telehealth because we actually had a group of faculty who did telehealth model, did a study about a model with rural primary care physicians where they used pharmacists in a telehealth way to improve diabetes A1C in their patients. And they actually addressed through telehealth like 90% of medication problems. And so even for pharmacists, you can have telehealth working. I was just out in eastern North Carolina earlier this week talking to a few community pharmacists, independent community pharmacists who are doing some really interesting, novel, innovative practice models to reach their communities. But they even talked about issues related to internet connectivity, not necessarily in their stores, but with their patients, with the population. And so, we need better infrastructure. How do we get to better infrastructure around connectivity? Or perhaps those brick and mortar pharmacies in these rural communities are the telehealth portal that patients can then reach out to or connect with their clinician team. And the question around team-based care was?
Just, you'd mentioned earlier about the opportunities for innovation in team-based care as you think about, all sorts of ways.
Yeah.
And I know there are a bunch of directions you might go. I don't know if you kind of want to think about underserved areas and what it brings together.
So let's talk about that. So I think, particularly in rural communities, the solution isn't to plunk one nurse practitioner out there or one primary care physician out there, right? It's really to how do you create a team of healthcare professionals that can work together, that can rely on each other. It could be lonely out there as well. So something that all of the health professions have been thinking about recently, the deans have gotten together and said, we're all doing individual things in rural communities. We're all trying to recruit individually from rural communities. But what if we do something interdisciplinary? People work in an interdisciplinary way now in the healthcare space. What if we recruit from these communities, from rural, underserved communities together, and figure out where, create pathway programs, create shadowing opportunities, create enrichment opportunities for students starting right from middle school to see what's possible in the healthcare space. help them make decisions around into what healthcare profession they want to go into, have them work together in these rural communities when they're doing all of their practice, their practicums, their experiential education, perhaps work on projects, mental health projects, for example, new models of care for mental health in these communities, whatever the communities need. And hopefully we can place them with good paying jobs. They see having a robust professional experience together. They see the impact that they're making in these communities. Are there new ways that we can work together, not just on the team-based care side, but all the way to the beginning around the recruitment side, and trying to have our youth in rural and underserved communities really see themselves in these roles and serving their communities in the future.
Great, thank you. Let me open it up to the audience, and I'm sure somewhere we have microphones, and if not, I can come running. Please.
Good morning. You spoke about a need for innovation, and you referenced AI in that conversation too. So there's plenty of companies out there that have built innovative things utilizing AI and whatnot, and of course in their innovation, that is an investment for them to develop that innovation. So recognizing that you're on thin margins and that innovation can bear a cost, how do you propose a business model there that suits all for technology innovation to serve health systems?
Great question. I think you have to have alignment and partnership with how would it be utilized and deployed at scale so that there's a business model that makes sense. And most of these companies have just sort of spawned things, they're there, but they're not integrated with anything else. And that, I think, is what has to happen. You need to have much more of a population-based health approach. How is this going to integrate with the way healthcare systems work? If it can't be integrated with Epic or its cousins, it's not going to be widely scalable. How do we think about partnering together? So medicine is corporatized now. How do we then work to develop solutions in a way that allows you to have scale to make a business model that works for all? And I think that the individual companies looking to make a margin for the individual company, the healthcare system's trying to have, a way to provide patient care and have margins to stay afloat. And given all the mergers and acquisitions, that's becoming increasingly extremely difficult, particularly if you're taking care of the public sector. And so given that 50% of the country has public insurance or more, we can't just say we're not going to worry about half the population. And I think the election this week showed that the general population isn't so happy with the status quo. And lots of people living in rural areas would like us to address their health concerns. So how are we going to do that? How are we going to work together to figure that out? So my concern is, how do we figure out how to take care of the entire population? And most of us here, I've spent my entire career at a public university and serving the people of the state of North Carolina. How do we think about business models that partner with public sector to scale things that have quality and meet the needs?
I can give you one example. So we have an organization within our school called Eshelman Innovation, which is really designed as both a therapeutics accelerator, primarily small molecule accelerator from discovery into application, and also a digital health venture studio. So they did a digital health sprint out in Asheville, North Carolina. They brought individuals from the community together to talk about substance use disorder and what are pain points in substance use disorder. One of them was around these golden hours where somebody overdoses, and if they don't get into the right care within 72 hours, you've lost them. But you do have this window of opportunity, but there is no coordinated care. So they created from the community an application that would connect everyone from EMT to all of the individual resources for a particular patient who has overdosed, to be able to connect them into care quickly. This is now being taken up by a number of counties across North Carolina, and is of interest to try and help impact substance use disorder. So there is a model there of funding for them, but it was a grassroots initiative started from the community, seeing what the gaps were, and so to the point around building with communities, I think that's a really good example of a potential model that could work.
I'll just say very quickly, I think conversations with clinicians and folks on the front line would go a long way, because there's still a healthy skepticism around AI, right? And if you're going to use it in electronic health records or clinically in some way, you've got to have faith. The clinician has to have faith in that. So I think bringing together the innovators, the technological innovators, and the clinicians and providers will be essential to really begin to get some faith in the system in order to integrate it into the electronic health record.
Thank you for so much for being here, by the way, and also that was a beautiful point. So I happen to work for a technology company, a custom software company in Virginia, but we design solutions basically for rev cycle, for instance, the least exciting, sexy part of healthcare. But in my work apart from that in North Carolina, one thing that I wanted to mention that I think we could really take a page from what UNC is doing and what you're talking about, multidisciplinary, multi-generational collaboration. One thing that I want to mention that's brand new and emerging in North Carolina, and this is coming from the Healthcare Financial Management Association, events that I attend and the boards that I sit on, when the business of healthcare side, when we actually look at the root cause, the frontline users, it's very similar to what you were saying, getting access to every person in North Carolina to health. It's also getting access to every frontline worker in healthcare. So when we start there and we look at keeping people safe and well and giving them what they need, then what I'm seeing in North Carolina, which I think we could do more of, I'd love to hear your ideas on that. Healthcare systems, it's very difficult to get under contract. It's very difficult it takes a year to get a hospital to change, and they can't rip and replace their technology. We can get all the people in this room to put their heads together and come up with a beautiful solution of how to get people paid, right? How to use AI and harness that. We could do that. But it's health systems, WakeMed, Duke, Cone Health. It's health systems working together in their rev cycles, collaborating and using student talent, right, to come up, say, root cause, and then what can we borrow, because we can't share our nursing staff yet, maybe. We can't share our technology investment yet, maybe. But perhaps there are ideas about that. What do you think?
Yeah, I think that
on the business, I guess the question is, on the business side, can we do what UNC is doing, because it's so awesome?
Yeah,
the case study competition witnessed that.
I think that there's lots of conversations again on how these things all work together, and I don't think there's enough of those. So we need more of them for sure.
And I think maybe a way to tie that together and wrap us up, as I know we're tight on time, is kind of rapid fire, work our way down. If you think about kind of the maldistribution of the workforce, kind of what's one thing that you'd like to see changed, be it policy, be it on the business side, and it can be something you've already gone to before. So you can go back to the well or something new, and let's just work from left to right. Samantha, starting with you.
In my world in mental and behavioral health, we are utilizing virtual platforms. I would like us to have a public-private partnership that takes a population-based health approach across the lifespan to be systematic, to be innovative, and to think about how we end up with the best outcomes. And I think it's a bunch of one-offs right now, and there's a huge opportunity to change that in all the different ways we've talked about to really have huge population health impact.
I'll go to the workforce, and I will say there's a misalignment between what clinicians want and what the system thinks what the system thinks it needs to do to, address issues in the workforce. Until we get more alignment between what the clinicians want and what the system imposes on the clinicians, I think until we get that alignment, we're not going to make great headway. So I think there does need to be better alignment between the workforce, and this could be where business steps in, right? This is where the business partnership could come in, and that is to help align both at the systemic level as well as at the provider level to really address some of the concerns.
Great, thanks.
Yeah, I think payment parity and incentives around team-based care, and removing all of the barriers to trying to get reimbursed, and pulling together a very fractured system.
Okay, great. Thanks. Let's give a big round of applause to our three panelists. While she's here, give a round of applause. This is Erin Leach, who has made much of the magic happen here. Thank you. And now Erin will share with us where we're going next.
Thank you all. Yeah, so we're going to take a quick 15-minute break and be right back in here for preparing healthcare workforce for AI in the industry.